Good evening, and thank you for attending this webinar. My name is Sharon Chen. I'm an ID physician and a clinical microbiologist at Westmead Hospital in Sydney. And tonight we are very privileged to have our panel and our speakers to tell us all about mucormycosis. I know mucormycosis is rather bread and butter, but it does rear its head and it does cause problems, and it still has many lessons to teach us. So we will begin by firstly presenting a case of a child, and this case will be presented by Dr. Annaleise Howard Jones, who's a staff specialist in microbiology and a pediatric infectious disease physician at the Children's Hospital in Westmead in Sydney. Thank you, Annaleise. Take it away.
Thanks very much, Sharon, and thank you for the invitation to join the webinar today. I'm looking forward to the discussions. Give me one sec while I share my screen. Lovely. Okay, so today I'm going to be presenting a case discussion, as Sharon has mentioned, of a significant case of mucormycosis in an immunocompromised child. I'd like to begin by acknowledging the traditional owners of the various lands on which we meet today, in my case, the Wangal people of the Eora Nation, and pay my respects to their elders past, present, and emerging. Importantly, I'd also like to acknowledge the parents of the child we'll be discussing today, who provided informed consent to discuss the case, including the details that we will go into. I was one of the clinical microbiologists involved with this case, and we also need to acknowledge the care of a very engaged multidisciplinary team, including pediatric oncologists, intensivists, neurologists, surgeons, and our infectious diseases colleagues, who I've listed at the bottom, who were closely involved with this case. So the case we'll be discussing today is of a 3-year-old girl. She was initially admitted via our emergency department with a short history of fever, a couple of weeks of lethargy, and some submandibular lymphadenopathy bilaterally. On her initial full blood count, she was found to be pancytopenic, and she underwent a bone marrow aspirate and review by the oncology team, and was diagnosed within the first couple of days with a new diagnosis of pre-B cell acute lymphoblastic leukemia, which was classified as standard risk. At the time of her admission, her blood cultures were negative, and her chest X-ray was clear, as shown there. She was febrile, and she was commenced on piperacillin tazobactam for febrile neutropenia, which is as per our local policy. She did commence on cotrimoxazole prophylaxis, and no antifungal prophylaxis was given, as she fell into a category of standard risk pre-B cell ALL, with less than 10% risk of invasive fungal disease. And this will be a topic we could discuss in our panel discussion today. She detraversed on day 6 and was commenced on her induction protocol, which was as per study 10, protocol 1A, and this did include the administration of prednisone at a dose of about 1.7 milligrams per kilogram per day. After about 2 weeks of her induction chemotherapy, she evolved new fevers, and around the same time, she also was found to have a steroid-induced hypoglycemia with blood glucose levels up to about 30, requiring insulin and input from the endocrine team. A couple of days later, she was noted to have some right hand pain, which progressed proximally and was associated with flaccid paralysis of the right upper limb. And shortly thereafter, she developed respiratory distress, initially just some transient tachypnea, but then progressing to significant distress requiring intubation and ventilation on day 29 of admission. Her neutrophil count throughout this time is shown here, and you can see that she was neutropenic through the duration of that period. On the right is the chest X-ray shown at the time of this deterioration, and her chest X-ray early in admission on the left. And you can see that she's evolved this very dense right upper lobe consolidation, which was not present on the first X-ray, as well as a small associated pleural effusion. A CT chest was performed shortly thereafter, and again, you can see the significant consolidation involving basically the whole right upper lobe, extending into the supraclavicular region, and also a small nodular lesion in the upper aspect of the left lower lobe. In the context of this lesion and also the concerning neurological findings in the right upper limb, she proceeded to an MRI brain and spine, which showed a very concerning finding, which you can see here. So a very large 7-centimeter diameter mass crossing the anatomical boundaries, centered in the right lung apex, but crossing into the thoracic inlet, the supraclavicular fossa, infiltrating the right brachial plexus, as well as the right epidural fat, and into the T1 to 3 vertebrae and ribs 1 to 4. There was no rim-enhancing drainable collection, and there was occlusion of the right vertebral artery and possibly the right subclavian artery. But there are no discernible lesions within the brain or the spinal. So obviously a very significant mass lesion in that right upper lobe, requiring extensive further investigation. She had a wide range of additional investigations throughout the admission, so a large number of blood cultures throughout the admission. Only one of these flagged positive with an Actinomyces species, which initially we thought could have been quite relevant, but on reflection was considered a contaminant. She underwent a bronchoalveolar lavage, for which the bacterial, fungal, and mycobacterial cultures were negative, as was the galactomannan. And a pan-fungal PCR was at this point pending. And her abdominal ultrasound, CT of the sinuses, MRI of the brain, a formal ophthalmology review, and multiple transthoracic echoes were all non-revealing of additional pathology in those locations. So obviously the point or the key diagnostic test at this point is going to be analysis of a targeted tissue biopsy to ascertain the nature of the lesion. The surgeons were consulted at this point due to the location of the lesion, particularly adjacent to and invading critical structures. They declined a wide excision or a resection of that lesion, and in fact declined an open biopsy. And there were concerns from the oncologists and the surgeons about biopsying the lung lesion directly due to concerns of forming a bronchopleural fistula. However, an IR-guided biopsy was performed of the portion of the lesion up in the neck into the supraclavicular fossa. And this was sent for histopathology, as well as for fungal, bacterial, and mycobacterial cultures. Here are the formal anatomical pathology images, courtesy of Dr. Ali Magimi, who's one of our anatomical histopathologists. And I think we can all agree there are considerable findings of concern here. So there's a significant amount of necrotic, fibrous and fatty tissue. And within that, it's really packed full of numerous fungal elements. In particular, we can see broad, non-septate hyphae with wide degree, 90-degree angle branching. And so this was obviously of grave concern for this child. So on the basis of the preliminary histopathology and some similar findings actually on our gram stain of that tissue, we contacted the mycology reference lab at ICPMR, Catriona Halliday's team, who fortunately is a 7-minute walk from my office, and we were able to take across a specimen, which Catriona kindly tested on her pan Mucorales acid, nucleic acid amplification test, which she'll be talking a little bit about later. And in fact, by day 2, we had the result of that, which was Rhizopus microsporus DNA was detected on that tissue biopsy specimen, as well as on the BAL specimen, which we had referred across earlier. And both of these results were confirmed by the Catriona's validated pan-fungal PCR. By the following day, the fungal cultures had also grown an organism which was identified similarly as Rhizopus microsporus, and the lactophenol cotton blue images are shown up at the top. And again, this isolate was referred across to Catriona's laboratory, and she kindly performed susceptibility testing. We can see the amphotericin B MIC is relatively favourable, where the posaconazole, isavuconazole MICs are really towards the upper end of the wild type distribution, and the pattern is largely what we would expect for a Rhizopus isolate. The bacterial and the mycobacterial cultures showed no growth other than the Rhizopus also growing on our blood agar plates. So at this point, there was again a very detailed discussion with the multidisciplinary team, in particular the surgeons and the oncologists. And unfortunately, because of the location and the extent of this lesion, there was no feasible surgical solution that could be offered that would be compatible with long-term survival and quality of life for this child. So the focus then turned to optimization of antifungal therapy. It'll be very interesting to have the opinions of the panel as to their thoughts at this point when we come back to the discussion in terms of choice of antifungal therapy, dose of antifungal therapy, dual versus single antifungal therapy. But essentially in this context, and with a child who had an extremely poor prognosis, the antifungal therapy was escalated. So liposomal amphotericin B had been started initially at 1 per kilo, very quickly escalated to 3 and then 5 milligrams per kilogram. The child had been started alongside that on voriconazole with the first suspicion of invasive fungal disease, but around day 33, when we had the diagnosis of Rhizopus microsporus, this was changed across to posaconazole, as well as an escalation at that point to 10 milligrams per kilogram of liposomal amphotericin B intravenously, again with little evidence for that high dose in this context, but in a child where the prognosis was fairly dire. You can see the posaconazole troughs were really quite high. So normally we would target a trough of around 1 to 2 milligrams per litre, but in the context of a higher MIC, and again, aiming to optimize tissue penetration, we aimed for a higher trough of around 4 to 5. And you can see that we attained and exceeded that. Fortunately for us, the child tolerated both of those medications. So the teams were watching very closely her electrolytes and creatinine in the context of the liposomal amphotericin B, as well as her LFTs and her other symptom complex. And actually, she managed to tolerate those very high doses. Nebulized amphotericin B was also added further on through the piece, again, with limited evidence, but I'm interested in the opinion of the panel there as well. Importantly, alongside that, her steroids were weaned and tight glycemic control was instituted, and she received a dose of GCSF with neutrophil count recovery on day 31. Unfortunately, despite these interventions, we saw progression of this invasive lesion with new lower limb weakness developing right more than left by day 36 of admission. And with further deterioration, a respiratory arrest occurred on day 55, and unfortunately the child passed away shortly thereafter. So there are a number of issues that arise through the course of this case. Just to summarize, we've got a proven invasive Rhizopus microsporus pulmonary and soft tissue infection in an immunocompromised child. This is manifested in the induction phase of chemotherapy and in the context of multiple risk factors. So a recent diagnosis of pre-B-cell ALL, but that being a standard risk categorization, significant hypoglycemia in the context of steroids, and in these cases, often there's been an unknown period of neutropenia prior to presentation and diagnosis of the case. And in the context of a surgical intervention not being possible in this case, unfortunately, we saw a fulminant outcome despite a timely diagnosis using molecular and culture-based diagnostics. So there are a number of discussion points that can come out of this case, particularly around diagnosis as well as prophylactic antifungals and treatment decisions. Perhaps I might hand over to the panel to explore these a little bit further.
Thank you, Annaleise. Certainly a lot of food for thought. At this point, I'll hand over to my co-chair, Professor Van Hoek Tan, who will kick off with the discussions for the panels. And I think all of us have written down some questions, and we'll take it from the chat. Van Hoek?
Yeah, thank you, Sharon. Good afternoon, everyone. I'm Van Hoek Tan. I'm an ID physician from the Singapore General Hospital, and I'm very happy to co-chair today's webinar with Sharon. Thank you, Annaleise, for a great case, although a very unfortunate outcome. Maybe we can start. I know Orla will be discussing drug doses, and then Catriona will be talking about the PCR. Maybe we can talk about some of the radiology and whether or not voriconazole. You all started on amphotericin first, right? Ambisome was first started. Why the voriconazole? Because I suppose when it crosses tissue planes, mucor would be a concern.
Why was the voriconazole started initially?
Yes, yes.
Yeah,
yes,
the voriconazole was started before we had a lot of the detailed CT and MRI imaging.
Okay.
So we started with the thought that aspergillosis was still very much on the table. And then as soon as we were concerned about Mucorales, and particularly with that confirmation, the switch was made across at that point to posaconazole.
Okay, thank you.
Van Hoek, may I ask a question?
Yes, sure.
So anyone on the panel, I know Annaleise gave the game away by saying that we had a Mucorales PCR, but let's take it back a step. What sort of tests would people have done? And, what do you think is the first line test, culture-based, microscopy, panfungal PCR, none of the above? So I thought I might ask Arun what would happen in, say, where you practice in India, Arun?
You might be on mute, Arun.
Arun, you have to unmute yourself.
Mute. Still on mute. Okay.
Yeah. Thank you, Dr. Sharon, for asking me this question. There are several issues in this particular case. First, I would say in case of this, such a big lesion, and that is also necrotic lesion. General, our experience is in case of without having the mass being taken out, just with a drug is very difficult to treat. Second important thing is that it is Rhizopus microsporus. I know it had shown MIC of 0.5, whereas in case of POSA and ISABU were 2. But I would again say that in case of the antifungal susceptibility testing of mucorales is not well standardized. Generally, what we find in case of these microsporas, they are resistant compared to the Rhizopus aeregeus, the sibling species of Rhizopus, which is more commonly caused the disease. And in case of India, we are seeing, we of course have the Rhizopus aeregeus is the most common one, but we are seeing a lot more this microsporus, Rhizopus microsporus is coming up. Rhizopus homothalicus is coming up. So there are many other species which are finding place in there. And a very recent study where we have shown that multicenter study, around 7% cases is Rhizopus homothalicus. And two species which are coming up more commonly in case of India is Rhizopus microsporus. And second important thing is that in case of leukemia, which is coming up again, leukemia earlier was not being seen so much, but it is coming up. And all these agents are very resistant other than Rhizopus microsporus, other than Rhizopus aeregeus. So in this experience, I think it is much issue is that it's a very big lesion, necrotic lesion, plenty of hyphae, very difficult the drug to achieve in the tissue. It may achieve in the blood for doing the MIC, but in the tissue to achieve so much in necrotic mass is very difficult. So until unless our experience shows in case of pulmonary mucormycosis, unless we have done the lobectomy, if possible, and all those, there is hardly any chance that our mortality rate goes very high in case of pulmonary mucormycosis, though we have drug. I don't think that when we have tried to evaluate having got the combination of the antifungal, there is not much use in this case that there is outcome-wise any much difference between this giving amphotericin or giving amphotericin plus posaconazole. So in case of the rhinocerebral, there are some experience of combination in a very patient who is having very high diabetes. But in case of lung, we have not seen so much of experience-wise. So again, I would say combination, very difficult to say of it. You have gone up to 10 milligram. I was thinking that this is just a desperate measures. Of course, we have gone. Generally, we don't cross 5 milligram unless it is a CNS infection is there. But it is not having CNS. In spite of that, the patient, we could not save the child. That's a common thing. Over.
Okay. All right. Van Hoek, should we take the questions in the chat?
Yeah, I think maybe one or two at the moment.
Okay. Yep.
I know, Annaleise, that there were many discussions with the surgeons about what to do or how to go about this. And Arun just stressed the importance of, trying to remove the mass. Would debulking have helped? I think that's one of the questions. I think we probably cannot get the whole thing out because of the morbidity and the poor quality of life that will ensue. Yeah, I think there's a question about whether or not just reducing the burden would have helped, and whether or not that was discussed and what the parents thought, etc., etc.
Yeah, thank you for the question. Most of the evidence I'm aware of certainly is around wide local resection as the surgical method of choice. I think we all would agree with that. And unfortunately, in this case, by the time the lesion was detected and diagnosed, it had already crossed into critical structures. So the role of the infectious diseases team in many of these discussions was actually to highlight the really critical role of surgery, if it could be performed, that we really felt that the child was very unlikely to survive without surgery, and that this was really the best option, even if we felt that that surgery might be quite morbid. But at the end of the day, the surgeons were quite clear in the fact that the location of the lesion really prohibited any surgery, because the sort of disfigurement, the removal of critical structures, it just wasn't possible. I'm interested in the thoughts of the panel on debulking. Certainly we didn't opt to go down that route. I think there's not a lot of evidence in that space, but the panel might have some interesting opinions on that too.
Yeah. Orla, what would you
We
have?
generally don't do debulking, mainly because sort of as has been pointed out already, you could create a fistula, which could create more problems than you already have. And really the sort of overarching sort of guideline is really around taking it all out, debulking down to fresh, sort of getting rid of it all right down to fresh tissue. Sort of maybe you could have done some debulking and maybe done serial. Like we recently had a case at the Alpha where we have done serial debridement of the chest wall in a Mucor case, and that's been quite successful, but that's probably the first time we've actually ever really done that. So not a general practice of ours at all to just do a bit of debulking. Maybe it could have taken away some of that surrounding crust, and that might have helped to get some penetration. But I think it probably would have led to the same outcome at the end of the day, but perhaps, you know, sort of poorer quality of life because they've been through surgery and maybe been in intensive care and things like that as well.
So there was,
Probably
sorry.
have a lot of experience, Arun.
I said about these aspects. In case of the debulking, if it is not possible, then it's a big problem in this. I would say that in a smaller lesion, patients' immunity is quite okay. In that situation, we really, because we have plenty of cases during the COVID time, when we have also the pulmonary mucormycosis. In certain patients, we could not do the surgery, but even then we could save the patient because patient's immunity was good. But this is a patient who is having ALL patient and already in induction and neutropenia, how long it is there. Of course, the steroid had come down, but how the neutrophil behave, that is very important issue. So all those factors would be important while deciding or what is in case of the outcome. So these are the factors which are there. Of course, I am sure the surgeons have taken all the chances if they could have done the debulking. But considering every other alternative or problem, they could not do the surgery. So that's a big problem.
Yeah.
Okay. There was a question in the chat from Dr. Jabin about the importance of amphotericin. So my question is for Catriona. How easy or difficult is it to, you know, get your genus and species out? And does it matter? And if we didn't have the Mucorales PCR, how would you provide the diagnosis?
So identification from culture, really we rely on the organism sporulating, and in particular something like amphotericin and Saxonea are quite difficult. They're known to be quite difficult to get to sporulate, in which case we can't identify it morphologically, and that's on the assumption that you've actually grown it. And then we would go down the path of identifying the fungus by ITS sequencing, which gives us a very reliable species identification, and is probably the gold standard, but it does rely on culture or culture positive result. And I guess I'll touch on the alternatives when I speak.
If I can,
please,
I have a small comment in this.
Yep.
For species identification, in case of management, we have important thing which already Kasur has raised. That is in case of amphotericin. You know, in case of amphotericin, we have seen the MIC against amphotericin is generally very high. In that scenario, we have seen that the posaconazole or isavuconazole we have not attempted, but posaconazole in that situation is a bit better compared to amphotericin B. We had a patient where there is a very interesting case after the above elbow amputation who had met with an accident. The mucor had gone to the amputation stump. It affected the chest wall, and debridement was not possible in that scenario. So, and the culture was not growing, but from the tissue itself, we could sequence and identify it as amphotericin. So because of amphotericin, we are given both hyperbaric oxygen and in case of this posaconazole, we could save that patient. So that's why I'm saying species identification from management point of view. If you look into it, there is few species which are very characteristically high MIC to amphotericin. So in those situations, it would be really helpful in case of management. Otherwise, there is not much difference in case of identification.
There was another question in the chat, and we about the use of checkpoint inhibitors and subcutaneous gamma interferon. Annaleise, did you consider these two options for this child?
They weren't discussed for this child. I'm not familiar with the recent literature on these two for Mucorales. I would be very interested. The two options that were discussed were the possibility of hyperbaric oxygen, which the oncologist had asked us about. And the second thing which our oncologists asked us about was whether we had any phages available that could be applied to this setting. And that's really a nod to the use of phages in our hospital for a number of really complex bacterial infections. And so that was also an interesting discussion.
I think we can move on, Sharon.
Yes. Okay.
Sorry, can I just
Yes,
say
please.
something? I will talk about the checkpoint inhibitors in my
Thank you,
talk.
Orla. Yes.
So that's the first thing. The second thing is, you wanted to talk about the radiology, Van Hoek.
Yeah.
Excuse me, when was the CT scan done in relationship to all of this? And could you put the picture back up again, Annaleise? Because I think there's probably a teachable.
Yeah, absolutely. I'll just pull it up for you.
Lots of lessons in this girl.
I know there are, yes. We could be here for 10 hours.
Sorry, 1 second. There were 2 CT scans done, so I might take you to the original one and then the second. Okay.
Sorry to be painful.
Before that.
Okay, this is the first CT
Yes.
test, which was done day 27, which was about a week after onset of the new fevers.
Yeah, so the top left one, as I look at it, so that looks very much like a reverse halo sign, which I think, as you know, is quite characteristic. Some people say pathognomonic, but it is quite characteristic of Mucor. And, perhaps even on that grounds, one could have started like Mucor-like treatment, like amphotericin or posaconazole or isavuconazole, sort of perhaps earlier. So I think it, particularly for, so some of our trainees, that is a very important scan to remember, sort of, because in that setting, you just, look at it and think Mucor straight away because it's a reverse halo sign. And so what a reverse halo sign is, it's opposite to aspergillus, and that's why it's called reverse. And it's got the sort of consolidation on the outside, and then it's got the ground glass opacification on the inside, as opposed to the halo sign, which is the other way around. So I just think, given we're going to talk about that, it's important.
Yes, thanks, Orla. The other thing that's quite interesting is for these lesions that are very near the mediastinum, it's always good to sit down with a senior radiologist and ask whether or not the planes have been breached, because even if the lesion were much smaller and you are very worried about the plane, that would be one indication to push the surgeons. I mean, here I understand that it's gone to the brachial plexus and the vertebral artery and all that, but that's another teaching point. From here, of course, it looks as if there's no plane between the SBC and the lesion, but you have to play with the windowing and all that. Yeah, that's another small point to highlight.
Yeah.
Okay, now we can invite Catriona to do her presentation.
All right, thank you. Can everyone see that? Yep, great. All right, so I'm just going to talk to you today about new approaches to utilising Mucorales PCR. I'd like to start by acknowledging the custodians of the traditional owners and custodians of the lands on which we sit in Australia, and pay my respects to elders past, present and emerging. So mucormycoses are the second most common cause of filamentous fungal infections behind aspergillus, and their incidence is increasing in both the Western world and the developing world. And this is due to increases in the number of susceptible people changes in antifungal practice and improvements in diagnostics, and in particular, I refer to PCR. And we know that early diagnosis and the prompt initiation of targeted antifungal therapy is key to improving survival outcomes. So if we look at the current diagnostic methods that we have available, we have culture. Now, culture has a relatively low yield, with only about 50% of those cases which are histologically positive actually growing the organism. It can be relatively slow, considering how quickly these organisms do grow. So it can take 3 to 7 days to actually grow it, and potentially longer for identification if we can't get sporulation. But it's really critical to allow us to perform antifungal susceptibility on that particular strain that you've got growing. About anywhere between 25 to 40% of cases of Mucorales are diagnosed by histopathology alone. The trouble with histopathology is it's never going to give you a genus or species ID. And it's not infrequently mistaken, Mucorales are not infrequently actually mistaken for aspergillosis. So that takes us down to the path of fungal biomarkers. Now, unfortunately, both beta-D-glucan and galactomannan are of no use in the case of for the diagnosis of Mucorales, and today, because these don't exist in the cell wall of Mucorales. And currently there are no commercially available Mucorales specific antigen tests. So that takes us to PCR. So there have been significant advances in PCR-based diagnosis of mucormycosis, and this has seen an increase in the number of diagnosed cases and has revealed changes in epidemiology. PCR has been used, or PCR can be used to directly detect these organisms in clinical samples, and studies have tested lots of different specimen types, so fresh and paraffin-embedded tissues, serum, bronchiolar lavages. The sensitivities are much higher in fresh tissue than they are in formal and fixed paraffin-embedded sections. Again, not surprising, considering the quality of your DNA is quite degraded. There was a study which looked at the usefulness of PCR to diagnose pulmonary mucormycosis from bronchiolar lavage fluid in 2018. It was only a small study, 10 patients with proven pulmonary disease, and the sensitivity of this assay was found to be 100% and specificity of 97%. And I guess the most important things to draw your attention to is that PCR was positive and the earliest indicator of disease before other tests that are available. And it was actually the only evidence of disease in 4 of those 10 patients. And as I alluded to in the earlier slide, about 25% of these patients were found to be co-infected with both Aspergillus and Mucorales. Oops. Sorry. Okay. So the next study I'll talk about is the use of Mucorales for screening. So the MODI-Mucor study, it was a prospective trial which looked at the usefulness of screening patients' serum to give you an early diagnosis of disease. 232 patients were enrolled prospectively in this study, and twice-weekly testing of serum was performed. And they used an in-house qPCR assay, which has the ability to detect Lichthymia, Rhizomucor, and Mucor and Rhizopus together. The study reported sensitivities of 85% and specificities of close to 90%, with positive likelihood ratios of 8.3 and negative likelihood ratios of 0.17. And again, as was the case with bronchiolar lavage samples, serum was positive 4 days before microbiological and histopathological examination, and 1 day before the first imaging findings. If the patient's serum became PCR negative within 7 days of receipt of liposomal amphotericin B, this was associated with a 85% lower 30-day mortality, whilst if they were persistently PCR positive despite therapy, it was 100%, had a 100% mortality rate at 6 months. So as Annaleise has alluded to, in standard of care for molecular diagnosis of Mucorales up until recently, for us was the use of panfungal PCR and followed by DNA sequencing. So this is quite a time-consuming assay. It's quite labour-intensive, which then carries its own costs, and it can take about 7 days to obtain a result from fresh samples, and potentially longer from formalin-fixed paraffin-embedded tissue samples. So Helen Tang was a microbiology registrar with us last year, and for her major project, she set about trying to develop and evaluate a PCR assay which would lead to kind of a faster diagnosis of Mucorales infection. And she did this by developing 2 different PCRs. The first PCR is a pan-Mucorales PCR, which targets the 18S region. And then if samples tested positive on that pan-Mucorales PCR, they would then reflex through to our targeted multiplex assay, which specifically identifies whether the sample is positive with Rhizopus oryzus, Rhizopus microsporus, or Mucor species. And it was this assay that we used in the case that Annaleise just presented. The reason these 3 kind of pathogens were selected for species-based identification was because in Australia, they represent the majority of our infections. Certainly there's other organisms, but this covers close to 70% of them. The assay was validated on a variety of specimen types, fresh and paraffin-embedded tissue, bronchiolar lavage and washings, fine needle aspirates, CSF, and other fluids. So if we look at, once we actually worked out that these PCR primers worked well on pure cultures of a variety of Mucorales pathogens, as well as they didn't work on other fungal pathogens and bacterial pathogens that could potentially be found in some of these specimen types, we went back and looked at 166 of our archived clinical samples that had gone through panfungal PCR. Some of these were positive with other fungal pathogens, such as Fusarium and Scedosporium, but 70 of them were positive with Mucorales DNA. So the other 96 were found to be negative for Mucorales on our panfungal PCR. And reassuringly, all 96 of these negative samples were negative on our pan-Mucorales PCR. So if we then look at the 70 expected positives, we did obtain positive results for 68 of these 70 samples. One of the samples was deemed invalid, and that was because no human DNA was able to be detected in this sample. So it had potentially degraded, or there was little sample left when we extracted anything new. And then the other sample was a false negative. This sample came back, had been collected about 4 years ago. And so potentially this had just, again, degraded during storage. So then those 68 positive samples from pan-Mucorales were then put through our targeted genus and species-specific PCR assays. So from those assays, we obtained 15 positive results for Rhizopus oryzus, which matched as we expected, 17 positive results for Microsporus, 6 positive results for Mucor species. And then we had 30 samples that were negative on this targeted assay. Of those negative, 20 of them were concordant in that they were positive for other Mucorales species that were not Rhizopus oryzus, Microsporus, or Mucor species. So 20 of these were as we would expect, but we had 10 discordant results. If we look at the Mucor species, the 2 Mucor species that were discordant were actually positive with Mucor amphibiorum, and we found that this species didn't amplify in the targeted assay. And As far as what this means, well, Mucoamphibiorium is actually not really considered a human pathogen, so we weren't particularly concerned about that being missed. And then we had down to 8 discordant results. 1 of those was a Rhizopus oryzus and 7 were Microsporus. Now, all 8 of these samples tested positive with quite high crossing points in the pan-Mucorales assay. So it's possible that these 8 discrepant results were actually indicated that perhaps they're at the limit of detection of these targeted assays. So if we look at this table here, you can see that the pan-Mucorales assay had 99.4% agreement with our pan-fungal PCR and sequencing. And then the more targeted assays, yes, Microsporus was perhaps a little bit less agreement, but that was mainly due to those quite high crossing point samples. But all of them had really good sensitivities and specificities regardless. So with regards to what happens next, well, at the moment, we're now trying to, so certainly this assay has the potential to change our current process in that we have the ability to get rid of some pan-fungal PCRs and instead run the pan-Mucorales PCR and the targeted assay. But ideally, we actually want to try and combine our pan-Mucorales PCR with our current in-house Aspergillus PCR, so that we have the potential to also detect co-infections, which, as I said before, it's suggested that between 30 to 45% of cases may be co-infected. So despite all these really encouraging results with the use of Mucorales PCR, it wasn't included in the EORTC MSG ERC updated case definitions in 2020, and its own Mucorales PCR is only moderately recommended by ECMM and MSG ERC. And that's really because of the lack of commercialization and standardization of these methods, which is what you really need to ensure consistent performance across different healthcare settings. There are 3 commercial Mucorales PCR assays that are available, which detect a variety of different genera and or species. So we've got the Mucogenius, the Mycogene, and the Fungiplex, and their manufacturers down here. Now, these assays were really well reviewed in this publication here in 2022. The biggest drawback of all these assays is that they had really very little clinical evaluations published in the literature. So the Mucogenius, which is produced by Pathognostics, has been shown to work well through the Fungal PCR Initiative group to detect the clinically relevant Mucorales species in about 3 hours, but it does lack extensive clinical validations. One small study of pulmonary samples demonstrated good performance with sensitivities of 90%, specificities of over 95%, but it did miss a case with a low fungal burden. Another small study which looked at the usefulness of this when screening blood samples reported sensitivities of about 75%, and again, it preceded microbiological diagnosis. And then another study that looked at the utility of this commercial assay and compared it to a well-used in-house PCR assay found that the Mucogenius had a lower analytical sensitivity than their in-house assay and decreased detection of Lichthymia corymbifera, but they did detect 2 additional non-targeted species, as Saxonea and Syncephalestrum. There was another study that was published last year which looked at the comparing the other 2 commercial assays, so the Fungiplex from Bruker and the Mycogene assay from Adamtech, and then again compared it to their in-house real-time PCR assay. They retrospectively looked at 58 PCR positive samples and found that the Mycogene, which is in blue on this graph, was superior to the Fungiplex assay, but it was not able to identify to the genus or species level. And certainly the in-house assay was better than both the commercial assays. So finally, I'll just draw your attention to a systematic review and meta-analysis that is about to be published, which Lottie Brown led, which looked at examining the performance of PCR to diagnose mucormycosis. So of the 4,697 articles, only 26 of these articles met the inclusion criteria. 5,389 PCR reactions were included in those papers. There were 4,736 non-duplicate specimens, and 700 of the patients met the EORTC MSG case definitions, and then the 3,983 patients didn't. Quite a large variety of specimens were tested in these studies, for 39%, so the majority were bronchiolar lavage fluid samples, followed by blood samples, fresh tissue, formalin-fixed paraffin-embedded tissue, and then 13% were mixed specimens, and that was because there was insufficient data to actually tease out what specimen type they were. So if we look at all those specimens combined, overall, PCR across all the different specimen types had a sensitivity of close to 92% and a specificity of over 95%. If we look at the different specimen types and break it down, certainly the sensitivity and specificity was excellent for bronchiolar lavage fluids, and it dropped then with tissue samples, fresh tissue samples, and blood samples. There was no blood samples. That asterisk is just to indicate that there was no difference in performance of whether it was a serum blood specimen or plasma. And then, not surprisingly, sensitivity was lowest in formalin-fixed paraffin-embedded tissue samples. And that's because it's well known that the quality of the DNA is quite degraded through all the paraffin embedding and then deparaffining before DNA extraction. There was no significant difference found in the performance of qPCR versus conventional PCR. The specificity was higher in case control studies compared to cohort studies, but the sensitivity was higher in the cohort studies compared to the case control studies. A wide variety of or broad range of disease prevalences was included in these studies, and there was reduced specificity in the COVID population compared to the other populations, but there was no real significant difference in sensitivity. So the results from this study have implications on diagnostic guidelines for mucormycosis. And I'll start with saying simply that a PCR positive result is indicative of mucormycosis across all specimen types. But it's really important with any PCR, no matter what the PCR is for, that is always taken into context with clinical and radiological evidence, and certainly also the strength of the qPCR signal. PCR and bronchiolar lavage fluid is recommended for patients with suspected pulmonary mucormycosis, and PCR on blood and bronchiolar lavage fluid is recommended for high-risk patients, whether they're patients with hematological malignancy, burns patients, perhaps patients who've had traumatic injury, or in the case of outbreaks. But in the absence of the ability to obtain a bronchiolar lavage or tissue sample, blood is adequate for diagnostic performance if you can't get these other ones. PCR is on fresh tissue is recommended over formalin-fixed paraffin-embedded tissue, and a negative PCR on formalin-fixed paraffin-embedded tissue can't exclude a diagnosis of mucormycosis. qPCR is recommended over conventional PCR. And finally, PCR should not replace conventional microbiology, because we do need conventional microbiology for formal identifications and in order to perform antifungal susceptibility testing. And I'd just like to thank Helen Tang, whose project this was last year, for all her excellent work, and Sharon Chen for her co-supervision and carried the seal. Thank you.
Thank you, Catriona. Sharon, you think we have time for a question or two, Sharon?
We do. We can split. Maybe we should take some questions on this section first, and then we'll have. So there are some questions in the chat. Shall we start with that?
Yeah, why not, Sharon? Shoot.
Okay. So there was a question, Catriona, about primer and probe sets and which targets are the preferred ones for Mucorales. That was the first question. And there was another question about paucity of fungal DNA and how you deal with the cell wall. So let's do the cell wall first. maybe.
Okay, cell wall. So I guess if you can't bust open the cell wall, you can't get good quality DNA. So I would always recommend mechanical disruption. I guess not dissimilar to what you would need to do with TB as well. You really need to bust open that cell wall. Whether that's bead beating, you can use different enzymes to help you with that as well. The other question, Sharon, was to do with the primers sets. So the targets, well, the pan-Mucorales targets the 18S gene. We looked through the literature and had a little, we tried a few different sets and so we, papers that were published in the literature. I don't have that in front of me, but we have certainly submitted the results from this study for publication, and so that will come out in due course. The ITS region is certainly better for giving you a species identification. So the targeted assays, all three targets target the ITS region for Oryzis, Microsporus, and Mucor species.
Okay. What about non-ITS targets?
Well, so there are, I mean, you could potentially look at other regions. The trouble is the ITS is multi-copy, so you immediately increase your sensitivity when you can target a multi-copy region. Other regions, which may be more specific for Mucorales, I think it's the COT-H, but it's not multi-copy like ITS or ribosomal DNA gene cluster is. So I guess I would always, given that the majority of your clinical sample is going to be human DNA and only a small amount will necessarily be fungal, I would always encourage a multi-copy target.
There is another question for you, Catriona, but we might just ask Arun as well, as whether his lab in Chandigarh uses PCR for Mucorales and how he positions the PCR in the diagnostic algorithm. Arun.
I rather have a question to Catriona.
Okay, sure. Sure.
The question which is when we are, because we have also tried with the molecular identification and also going for the PCR. In case of the ITS, the main problem happens is that cross-reactivity with Aspergillus is quite high. If we are using the 18S, where the Mucorales specific, that is much better. That's why I'm wondering, you have got 30 to 40% co-infection which you have shown, whether that is because of the cross-reaction that had shown or not. That was my question.
So I haven't, I guess the samples that we used for validation, we knew what they were positive with other organisms. Some of them were positive for Aspergillus, and these were negative on our pan-Mucorales PCR. Some of them were positive with things like Fusarium, Scedosporium. We tested pure cultures of all the different fungal pathogens that we'd be likely to come across, and both the pan-Mucorales PCR as well as the targeted PCRs were specific for the organism we hoped they would be. So they didn't cross-react with Aspergillus. But I haven't done with our specimens, because at the moment, if we have a sample that's positive for Aspergillus, it won't go to pan fungal PCR, which is our accredited PCR that we have at the moment. So we stop testing them because we'll just amplify Aspergillus DNA or a mixed signal.
Does that help, Arun? Does that make sense? Yep, thanks. Catriona, there was a question in the chat about antifungal susceptibility testing. What is its role? Do you do it on all Mucorales isolates? If you do, what method do you use? And how do you interpret the MICs?
Okay, so there are no interpretive breakpoints. So we don't give an interpretation. We do test, generally we would test any Mucorales that we actually grew. We would perform susceptibility testing when it's come from when it's deemed to be significant. And that's because we like to have an understanding in our own, local area what, antifungal profiles are, what the pattern is likely to be. I guess so that when you don't have a culture, you've then got a bit of an idea of how, what it's likely to be in the absence of culture. So yes, we would do susceptibility testing if we have a sporulating and a growing culture. And the method we use is we use the commercially available Sensitita assay, but we use it according to CLSI methodologies. So we don't use UCAS, we use CLSI methodology.
Banhok, over to you.
Okay, thank you very much. I think we shall move on. So it's my pleasure now to invite Orla Morrissey to talk about high-dose amphotericin and the newer antifungals in the treatment of mucormycosis. Orla, please.
Okay. Can everybody see that and hear me?
Yes,
Great.
yes.
Great. Okay, thank you. Thank you very much to everybody for inviting me to speak at this webinar. It's a great honour and pleasure. So moving on. Okay, so these are my conflicts of interest. And I'm just going to give a little bit of a summary introduction. I know a lot of this is being covered, but I just think I want to set the scene for treatment. Aspergillus, Mucorales, Mucorales are a very common organism. They're the second most common mold after Aspergillus. They compose 8 to 9% of invasive fungal infections in stem cell transplantation patients and about 2 to 3% in solid organ transplantation patients. They're associated with a significant cause of morbidity and mortality, and I think the case that Annaleise presented actually really exemplifies that. One of the big things, as we've talked about, is the infection. The organism spreads very rapidly and ignores tissue planes, but also I think is going to be outlined in this study that there's very limited treatments available, both current and coming down the pipeline as well. There are 5 pillars of treatment antifungal therapy, which I'm going to mainly concentrate on in this talk, surgery, adjuvant therapy such as control of diabetes, hyperbaric oxygen, granulocyte transfusions, and GCSF. There's also reversal of the underlying disease, such as diabetes, and then therapeutic drug monitoring, which Annaleise has also very nicely illustrated in her talk. So I'm going to talk about amphotericin B, first of all. And it, so really is first-line treatment. It's recommended as first-line treatment in a number of guidelines. One of the reasons is because most of the data lies with that. Alternatives to that are posaconazole modified release tablets and intravenous, and isavuconazole as well. They're generally second line or alternative. So if a patient has baseline renal impairment or developed renal impairment on amphotericin or doesn't have a response to amphotericin, then they would switch to posaconazole. There's not or isavuconazole. There's not a huge amount of data available on either of these agents, but I've illustrated in the boxes 2 studies, the Move On study for posaconazole, where they compared modified release tablets or intravenous posaconazole to liposomal amphotericin B B and posaconazole, or to liposomal amphotericin B alone. And, sort of the posaconazole did very, very, very well in comparison. The posaconazole did very well in comparison to the other agents. However, we must remember there was a small number of cases, only 5 cases in that. There's also, in terms of isavuconazole, the VITAL study, which looked at proven or probable mucormycosis, and was first-line treatment with isavuconazole, and they were compared to controls from the Fundiscope registry, and they were actually very favorable responses between both the historical controls and the isavuconazole as well. So that study is, sort of also gives some evidence that we can use posaconazole for treatment of mucormycosis. I'm not going to talk about risofungin and olorifim because they really don't have any activity against Mucorales agents, so there's not a lot of point in talking about those agents in this talk. So just going on to high-dose amphotericin, the guidelines they do recommend, not only the Australasian guidelines, but also the ECMM guidelines, or the global guidelines recommend 5 milligrams per kilogram of a lipid formulation for non-CNS disease. But if the central nervous system disease, it's recommended to have 10 milligrams per kilogram of liposomal amphotericin. And that's based on a number of small case series and a number of animal studies as well. Amphotericin B lipid complex is not recommended for CNS disease, and that's been extrapolated from an animal study on candidemia, where it actually only showed partial clearance of the infection of the candidemia in that setting. So one of the big studies that has come out that has provided the basis for using 5 milligrams per kilogram as opposed to 10 milligrams per kilogram is the Ambizygo study, which came out in France, and they looked at 40 patients who had proven or probable mucormycosis, and that was in the nearly 2 decades ago, 2007 to 2011. Most of the patients are those who had a hematological malignancy, and they were given scheduled to give 10 milligrams per kilogram of liposomal amphotericin B as monotherapy, just to not confuse things, and that was aimed for a month, and surgery as appropriate. So a lot of patients had surgery. 71% of the patients had surgery, and 36% had a complete or partial response. So they had, sort of full resolution or partial resolution of the radiological features, and also the clinical signs and symptoms as well. And then at 12 weeks, 45% of them actually had a response, which probably indicates that if you're going to survive at 4 weeks, you're probably going to survive at 12 weeks. And the disease is a disease that causes mortality early on after diagnosis. And when they looked at side effects, they found that 40% of them had an increase in their creatinine. It doubled, and not in all, and in 37% of the patients that was irreversible. So they really felt that there was no difference in comparison to historical controls between 5 milligrams and 10 milligrams, but with the 10 milligrams, there was much more toxicity. And so based on that, they recommended the 5 milligrams per kilogram. A more recent study from Japan has also confirmed that. They looked at 82 cases, or more than double the number of cases, still mostly hematological malignancy patients, and the most common site of infection consistent with that was in the lungs as well. But a number of the patients actually had disseminated disease, and they found the mortality was 41.5%, not any different from historical controls, and also there was no difference, as you can see, in survival in the graph between those who had greater than 5 milligrams per kilogram per day compared to 5 milligrams per kilogram per day. And they did a Cox proportional hazard model as well to adjust for confounders, and found that there was no statistically significant difference even after adjusting for confounders. So again, confirming what the Ambizygo study actually proved, and really helping us to decide that really in most situations, 5 milligrams per kilogram of amphotericin, of a lipid formulation of amphotericin is adequate for non-CNS disease. So looking at some new drugs, looking at MAT 2203, and this is a new oral amphotericin B. It's been studied very much in Cryptococcus and is looking very promising in that setting. It's a lipid nanocrystal formulation, so it's like very long thin sheets that are curled up. and within that, the amphotericin is sort of bound to lipid, sort of a lipid bilayer. And what it does is when it gets to the site of infection, it actually causes pores to develop in the membrane, and for the amphotericin to actually get into the cell, so acting at the site of infection and reducing toxicity. In a neutropenic mouse model study, they compared 15 milligrams per kilogram, as you can see in the survival curve at the end, or the survival graph, that 15 milligrams per kilogram of MAT2203 was as effective as 10 milligrams per kilogram of liposomal amphotericin B, and that it was much better significantly better than placebo. However, when you got to higher doses of MAT2203, that actually wasn't any better than placebo. So it seems that 15 milligrams per kilogram, if you're going to, sort of think about using it, obviously we're a long way off that because we haven't got any human clinical trials done, but that seems to be the best dose, 15 milligrams per kilogram. Having seen that there were good survival curves, they went and looked at lung tissue burden and how much it was reduced, and also brain tissue burden, how much it was reduced by using treatment of MAT2203. And there was a significantly better reduction in lung burden and also in brain burden for liposomal amphotericin B compared to MAT2203. So there's still a lot of work to be done on this, and it may not end up panning out to be an effective agent for mucormycosis, but certainly something that at least we should actually look at given the lower toxicity. Phosphoanagepics, sort of is also used to previously known as APX001. It's a glycosyl phosphatidylinositol inhibitor, also known as a GPI inhibitor, which is much easier to say. And what it does is it inhibits inositol acetyltransferase within the endoplasmic reticulum. So it actually, it prevents the production of the GPI anchor proteins, and those are actually needed to anchor the beta-D-glucan across the cell wall, and it actually maintains cell integrity, and helps with adherence and invasion into the host cells as well. So if you break that anchor protein, then you actually destroy the integrity of the fungal cell wall, and actually then allow the drug to actually destroy the fungus, helping to treat the infection. So looking at it for Mucor, it has very good activity against Scedosporium and Aspergillus, but looking at it in Mucor in terms of in vitro studies, it has been quite disappointing with MEC values of greater than 3 for most organisms except Mucor succinylloides. So, sort of it doesn't look right when you do in vitro studies. However, when you actually look at it with a mouse model, when you actually sort of test two different strains, one which has got a low MEC and one which has got a higher MEC, and also you look at combining it with ABT, which is aminobenzotriazole, which is a non-selective triazole, which has got a suicidal activity, generalized non-specific inhibition, and what it does is it increases the amount of time of exposure and the concentration of exposure to Manigepics, which is the prodrug. But when you actually do that, you find that when you do in vivo studies with animals, you find that it actually does decrease the burden of conidial equivalent in the lung tissue and also in the brain tissue, as you can see here, as effective as isavuconazole in this graph. And it's been looked at in a phase 2 study. It's a small open label non-comparative study. It's being completed, but I can't see any evidence of it being published at the moment in the literature. So hang on for that, and we should be able to see that soon. So looking at the tetrazoles, one is VT1161, which is osteoconazole, and VT1598. VT1598 still hasn't got a name to it. I'm sure it will at some time soon, and these are the structures of them here, as you can see in the pictorials. And what they do is they have a similar mechanism of activity for azoles, but they have a very decreased affinity for the human cytochrome P450 isoenzymes. It's really targeted at the fungal, selective for the fungal cytochrome P450. So you get less drug-drug interactions and you get less side effects. That's the principle anyway. So when they've done some studies looking at in vitro work, Rhizopus arises, the MICs are looking good, but when you look at Rhizopus delamar, the MICs are less favourable, and they need to look at the other species within the genus Mucorales to have a better look at it as well. But when looked at again in vivo in mice models, we find that sort of it's as good as liposomal amphotericin B at 15 milligrams per kilogram, and the tissue burden sort of is reduced, not as much as liposomal amphotericin B at 15 milligrams per kilogram, but reduced compared to the placebo. So it seems to have a similar activity to high dose liposomal amphotericin B. Looking at further detail, when you actually use it as prophylaxis in a mouse model, immunosuppressed mouse model, and when you use it as prophylaxis, you give it day -2 to day 0, and then you actually infect the animal after that, and you look at that compared to posaconazole for the same duration of days, which is prophylaxis posaconazole. Follow or compare it to historical control, which is a control, which is delayed treatment, which starts day +1 after the infection of the animal to day +7. And when you actually do a survival curve, it is significantly better than posaconazole, whether it's delayed or prophylaxis. And then also, when you look at the lung tissue, it definitely is much better than prophylaxis and placebo, but it has equivalent activity in terms of reduction of fungal burden within the lungs and within the brain compared to delayed posaconazole. Similarly, looking at continuous therapy, where you actually give it from day +1 to day -2 to day +4, and day 0 is the day of infection, and compared to posaconazole given for the same days, and then compared to delayed posaconazole, which is given a day +1 to day +7. Survival curves look very good for VT1161. It seems the mice seem to survive for much longer compared to the posaconazole or the placebo, and similarly a significant reduction in lung and brain fungal burdens compared to the placebo, and comparable to that of delayed posaconazole. So again, seems to be good as a treatment and also seems to be good as a prophylaxis, but we must be mindful that this is only looking at one species of Rhizopus, and also it's only looking at animal studies. We actually need to do further studies on other species, and we also need to do human studies as well. VT1598, looking at it in vitro, it seems to have reasonably similar geometric means compared to spread of MICs compared to posaconazole and amphotericin. And then when you look at the MIC or MEC 100%, that's 100% inhibition, the value is actually higher than posaconazole or amphotericin, but sort of may well be achievable. So sort of encouraging results, but more work needs to be done in this area. The Brexafungerp is a synthetic fumifungin, and it actually has similar activity to the iconic candidates. It's actually slightly structurally different. It has no in vitro activity. Its MEC values are greater than 8, but in vivo, similar to other agents like fosmanogepix, ipex, it does seem to have good activity in vivo in a neutropenic model. And when they looked at Rhizopus arises delamar, the survival was significantly better in mice treated with Brexafungerp compared to the placebo, and also similar to other agents such as posaconazole and liposomal amphotericin B. When it was given in combination with liposomal amphotericin B, it had significantly better survival than when it was given in combination with posaconazole. And similarly, the burdens in the lung and the brain were also reduced with the combination of Brexafungerp and liposomal amphotericin. This is giving some indication that maybe combination therapies with some of these agents may well be the way to go in the future. But again, further animal studies need to be done, and then also human studies need to be done as well. Coming to immune checkpoint inhibitors, these are sort of very interesting sort of agents that we should be thinking about and should be looking at examining in larger clinical trials going forward. So what happens is that with the fungal infection, you get T-cell exhaustion because you get over activity. You also, sort of tend to get an immunosuppressive phenotype as well. And what happens, what the immune checkpoint inhibitors do is they actually reverse that so that they actually dampen down the activity related to T-cell activation and other cellular activation as well. So it seems to reverse the immunosuppression, which is something we really want with Mucorales infections. There have been studies done, all single case series looking at nivolumab with or without interferon gamma, and you think that interferon gamma will work very well because it restores immunity in patients with an invasive fungal infection, but it seems to be the literature is looking like it might be more than nivolumab, might be the better agent that has activity as well. And there's been one particular described study looking at a patient with polytrauma and abdominal mucormycosis, and the patient only got better once they had nivolumab and interferon gamma in combination. So I think this is going to be a very exciting area for us to do research in terms of mucormycosis and other fungal infections as well. They seem to have good activity against Aspergillus. But I think given our paucity of other antifungal agents for mucor, this would be mucormycosis. That would be a very exciting agent to think about. So there are also antibodies to COT-H and beta integrin. So COT-H are a family of protein kinases which play a role in morphogenesis, so stress adaptation, spore formation, cell wall structure as well. So very critical to Mucorales virulence. And it's found on the surface protein of the Mucorales, and it binds to glucose regulated protein 78 or GRP78 receptors, which lie on the surface of the nasal cell and the nasal epithelial cells. So that's how it actually gains its entry and causes invasion. The receptors, which rely on the human nasal epithelial cells, are increased during times of increased iron, glucose, ketones. So clearly a diabetic ketoacidosis sort of state. So therefore, so that's, might be an underlying mechanism as to how you get rhinocerebral orbital disease in those patients who've got diabetes and diabetic ketoacidosis. And they've created anti-GRP antibodies and they tested them in mice and found mice who had DKA, and they actually protected the mice from invasive mucormycosis. And mutants have also lost the ability to invade endothelial cells. So some of these anti-COT-H antibodies may well again be something that we could explore as an adjunct to antifungal treatment and surgery, etc., to treat mucormycosis in the future. So it seems to be more related to the diabetic sort of component, whereas in the hematology population, it's usually pulmonary disease. But never fear, there's a COT-H as well that is effective in causing invasion in pulmonary mucormycosis, and it does this via an integrin beta-1 receptor, and these are expressed on the surface of the alveolar epithelial cells, and they cause downstream activation of epidermal growth factor receptors. And there have been studies, again, in mice looking at anti-integrin beta antibodies, and they seem to protect against pulmonary invasive aspergillosis. So this also might give an insight into why, hematology patients are more likely to present with pulmonary disease, but diabetics are more likely to present with rhinocerebral orbital disease. Again, providing another window of opportunity for us to think about treatments for mucormycosis. So I think in conclusion, we can say that antifungal, the current agents we have are very limited. There's only a few ones coming down the pipeline that we need to do more studies, more in vitro studies and more animal studies in particular to look at the precise efficacy of these new agents coming down the pipeline as well. And I think we need to do lots of clinical studies to see the effect of these agents in humans as well. There's still an ongoing need for novel antifungal drug development for mucormycosis, and I think that the next horizon is the use of immunotherapies and antibodies to either use alone or in conjunction with our current antifungal agents, will be the things that will need to be tested as well. And again, clinical studies need to be performed. And these are some references for your benefit that you can look up. Okay.
Okay, thank you very much, Orla. That was truly cutting edge. We're almost running out of time, but I think we can take a few questions, right, Sharon?
Yes.
Yeah, and I saw a few that were really good. Maybe one for Arun. I think you did mention this briefly, but is there specific species within the mucormycosis which tend to have characteristic resistance patterns regarding amphotericin and or the azoles? Maybe you can give clinicians a rule of thumb as to which types of Mucorales we should be preferring, an azole versus amphotericin?
I tried to answer this question, and this is very important because we all do antifungal susceptibility testing, and this antifungal susceptibility testing has a lot of bearing in case of managing the patients. Now, the thing is that in case of mucormycosis or mucorales for doing antifungal susceptibility, till now we don't know very well what are the breakpoints. So here, rather species identification, if it can give the clinician that what drug should be given, that would be very important. That's why I said that in case of the apophysomiasis, we are seeing that this is very resistant to amphotericin B, which Kasur also tried to highlight in case of the Pakistan. They have seen such situation. Similarly, Cunningham, Lichthemia, these are the species or these are the genus and having the species which is found to be quite resistant to amphotericin B and also Rhizopus microsporus. So I'm saying that these are the species where you have to be careful. And if you see in the newer drug like isavuconazole has been found to be quite good in Rhizopus aereus, but in other genus, the isavuconazole susceptibility is not so good. So I would say that these are the species, though we have maximum number of cases, Rhizopus aereus, but the other species, when it comes, please look into this issue. Certain species having got, in general, had intrinsic resistance in case of mucorales which have been there. Over.
Thanks, Arun. There's a question for Orla about the duration of antifungal treatment. I mean, this poses quite a challenge for many of us. Orla, are there any guidelines or pointers that you can share with us about how long to, before you move from IV to oral, from, intensive phase treatment to step down? What are your thoughts on it?
Usually for IV to oral, it's generally when the patient is clinically stable, and clinically improved as well. So radiologically they've done some surgery. Sort of blood markers are looking good as well. So obviously oxygenation and things like that as well. In terms of duration, there's no data in the literature about durations of treatment. There's nothing like, so you have a Staph aureus or candidemia, like that. It's really expert opinion. And also, so we've got to remember that these patients may well have ongoing immunosuppression. So whether you actually stop the treatment in that setting or whether you kind of convert them to secondary prophylaxis, which for some drugs is exactly the same dose. It's just kind of a naming or a classification that you may well need to continue the drugs, as long as they have immunosuppressed. So I think it just becomes an expert opinion as to how long you actually give, and it depends on the individual patient and what's going on with the patients, at the time in terms of duration. And I think the good yardstick is a long time.
Yes, thank you, Orla. Annaleise, this was a case of a child. Are there any special considerations for children?
I think the biggest issue that we face in pediatrics is that a lot of our data is extrapolated from adult studies. So where data is lacking for duration or treatment options in adults, we have even more of this problem in pediatrics. The other thing that was springing to mind as Orla was speaking about emerging therapies and new opportunities for research was also the importance of including children in these exploratory studies, because some of the issues that we run into is actually around drug access. So where we have children, not so much with Mucorales infections, but with other infections that might warrant use of novel agents such as Lorifem or something like this, often accessing that drug through special access schemes or compassionate access is very problematic, because the data is much less solid in pediatrics. So really including children in these research projects is really important in the clinical trial space, so that that data is available.
There is a last question from Chris Heath to everyone. Just let me get it up. Chat. It's in the wrong chat. Sorry.
I've got it, Sharon.
You got it? Thanks, Mark.
How, Orla, would you plan the process? It's actually directed at Orla. How would you plan the prospective study of a new antifungal compound for mucormycosis in human patients?
Haven't really thought about it in great detail. I think I need a couple of cups of coffee in a couple of days to actually do such a thing. But I mean, it's going to be very hard to do a randomized controlled trial. So, so maybe you do a phase 2 study, sort of looking at particularly safety, and obviously, sort of safe efficacy would be part of that as well. And you may well have a number of cohorts within that, sort of, I think perhaps we need to start thinking about looking towards the oncology and hematology groups for how to actually do studies in this setting. They seem to do studies very readily with small numbers in the hematology population of new products. So maybe we need to start thinking about sort of structures like that for doing sort of studies. But yeah, no, a bit vague. Give me a couple of days and I'll come back with something more concrete.
It is very difficult. The VITAL study, as you pointed out, Orla, actually had historical controls.
Yes.
From Fungiscope.
Yes, that's right. Yes. Yes.
It's the same problem with the Lorifem study.
Yep.
We need the controls for both aspergillosis and, for Scedosporium. Anyway, I'm afraid we have run out of time. So, Banhok, I think we close. Thank you for, co-chairing with me. Thank you to all our speakers and to the panel. And lastly, thank you to all the attendees. Appreciate the efforts. And there is a recording of this webinar that will be available on the AFWG channel, I think.
YouTube.
YouTube, is it? YouTube. YouTube, which you can hear tomorrow. And I think that will be useful, for those of us that were too busy to come this evening or this afternoon. You have, work to do on the wards, etc., etc. And we will reconvene in, I'm going to get this wrong. This is February, probably sometime early May for our next session. So thanks, everyone, and good night, good afternoon. See you
Bye-bye.
next time.
Thank you. A very enjoyable session. Really enjoyed it.
Thank you all.
Thank you.
Nice.
Thank
Thanks,
you. Take care.
Aaron, Annaleise, Catriona.
Thanks,
Orla.
Sharon.
Thanks, Sharon. Thanks.